Welcome to Parkinson Foundation Western Pennsylvania's monthly webinar. Today, the webinar is entitled Parkinson's Tests, Shaking Up the Field with Dr. Austin Oblack. Dr. Austin Oblack is a movement disorder specialist, neurologist with Independence Health, and we really appreciate your time today. I would like to also thank the sponsor of the webinar today, CND Life Sciences. And we are joined by Andrew from CND Life Sciences. Dr. Oblack will talk about some of the clues for a better Parkinson's diagnosis, as well as a current test and possible new tests and misconceptions. Dr. Oblack, thanks again, and please take it away.
All right. Well, thank you guys for having me. I am going to apologize right off the bat. My nephew's got me a little bit of a head cold, so if I sound a little stuffy and congested, I blame them. So if anything comes out a little too muffled, certainly just shoot a message in the chat. Try and ask for some clarification. I'll try and do as best as I can. And so, without any further ado, let's get going right off the bat. And so when we talk about testing, in an ideal world, we would like to have a test that does two things. It wants to be sensitive to capture the disease, and it wants to be specific to the disease that we are testing for. And so every test is framed around these two principles. And so I'm going to try and keep things kind of as simple as I can and really kind of discuss each test on that basis alone. And so when we talk about sensitivity, sensitivity is really the ability of a test to be positive when a patient has a disease. So for instance, the most minor symptom, the most minor clue of a disease, and you do a test, it always turns up positive in people that have the disease. Whereas specificity is the ability of a test to be negative if the disease is not there. And so, despite many different symptoms being present that could be positive for a test, specificity means that it is only going to be positive when that disease is truly there. Okay. And so, again, the ideal would be 100% sensitive and 100% specific of a test. And so with that information, let's get right into it. So not really labeled a specific test, but a clinical diagnosis of Parkinson's disease is probably the way most patients wind up getting diagnosed as a Parkinson's disease patient. It's based on many different things, really just a combination of the history. So, symptoms that a patient or a caregiver will describe whenever they come in for a visit, along with key physical exam findings. Um, Things that most people recognize as the cardinal features of Parkinson's. They have a classic type of tremor at rest, they're stiff, they're rigid, they may have postural issues and walking issues. And so really a clinical test means really just the provider is putting all of those pieces of information together to try and see exactly how closely it fits with the diagnosis of Parkinson's. Now, these numbers here, sensitivity of 90% and specificity 95%, is really for patients at any point along their journey with the physician to try and get diagnosed with Parkinson's disease. These values are a little bit lower when it's very early on in the disease, where features are much more mild. There aren't a whole lot of clues to help guide that. Where people may be jumping the gun and trying to diagnose Parkinson's early. That does open up some gray area where that diagnosis might be missed, either saying that it's not Parkinson's disease when it may in fact be early and still developing, or may say that it is Parkinson's disease. And again, symptoms have just not fully developed where it may be, in fact, a different disorder. And so a levodopa trial Sometimes, depending on what kind of resources you look at, this is considered its own individual test. I like to think of this as part of a clinical diagnosis because, again, the physician using the clues of the information in the exam helps guide you to the point where you will try medication. Now, part of the levodopa trial is okay, you try the medication, Parkinson's disease typically will respond to the levodopa therapy and at or by certain dose intervals. And so part of that trial is really just initiating therapy and increasing the dose until you get an effect. That's both supportive for a diagnosis, and in fact, it already becomes therapeutic because when that test is positive, that's still the medication that we typically will use firsthand to start treating Parkinson's disease symptoms. And so, in conjunction with the clinical exam, again, some things will respond to levodopa therapy. And so that's why sensitivity is a little bit lower on this. It's 70% and specificity for 80%. So it needs to be taken in clinical context. That's why we usually recommend when there's any kind of question, people usually would like to see a movement disorder specialist, not just a neurologist. But obviously that's resource dependent. But if there's any questions, certainly they can reach out to a movement specialist for a second opinion if they have any kind of doubt. Another type of scan test is this type of scan called a DAT scan or a SPECT scan. I'm going to trip over this, so I would never expect a patient to be able to convey this again to myself. But so the DAT scan is basically a dopamine transporter scan, and the SPECT stands for a single photon emission computed tomography. And so we usually just like to call it a DAT scan for simplicity. And essentially, what this is, whenever I explain it to patients, it's similar to an MRI but with some minor differences. You will go into a facility, they'll give you an IV and give you a tracer through the IV. And this tracer basically goes to a specific part of the brain in the basal ganglia, and that is the part that is usually degenerating in Parkinson's disease patients. We use this scan to see how well that tracer lights up that area of the brain. And in a normal person, that area of the brain lights up because it absorbs that tracer very well. In a Parkinson's patient, because that area of the brain is degenerating, it doesn't absorb that tracer very well. It doesn't light up very well. And so that's where we see the differences. There is some specific criteria for this test to be done. There are some time constraints. It takes about 4 to 5 hours for that tracer to get up to the brain to get absorbed. And so, we like people to be sure to wait the appropriate amount of time before they actually have the scan completed. Otherwise, it's not going to give us useful information. Another limiting factor with this is a lot of different medications can interfere with the results of the test. And so, it's important to always, discuss medications with the provider that's going to be ordering this test because a lot of different medications need to be held for up to 2 to 3 weeks before the scan is done so that it doesn't interfere with the results again. This is probably outside of the clinical testing, the test that has been widely used up until more recent years as the study to really kind of confirm or refute a diagnosis of Parkinson's disease. This one's pretty sensitive, about 85%. Again, 85% of the time people come in with symptoms, it correctly identifies them as Parkinson's disease and a specificity of 75 to 80%, being able to refute a diagnosis of Parkinson's disease when it's not truly there. So this is an example of one. On the left, you see a normal scan. And so, as I said, this tracer goes into the brain and it lights up these areas called the basal ganglia and putamen. These areas here is what we'd like to call the nice comma shape. And so that's a nice, healthy brain, good full absorption of the radio tracer as compared to an abnormal scan where you start to lose kind of that tailing off of the putamen and basal ganglia, where that would be considered a positive scan. Now, what I want everyone to pay attention to is we call it abnormal, not saying that this is diagnostic of Parkinson's disease. Other things can give this type of result that is not in line with Parkinson's disease. And so again, that's where we get into the numbers of not being 100% sensitive and 100% specific. So this is again just a clue in favor of a diagnosis of Parkinson's disease, but can't be used to make the diagnosis itself. And so another type of test that has been kind of more on the forefront within the last couple of years, excuse me, is an alpha-synuclein test. There are a few different types of tests that are right now available. And what these are looking for is alpha-synuclein, an abnormal protein that is seen to accumulate in Parkinson's disease patients. There's a couple different that we're going to discuss. First one being a skin biopsy. So this is an in-office procedure. It does need to be scheduled outside of the regular visits. It can't be done attached unless there's separate time accounted for that. For anybody that has seen a dermatologist or ever had something called a punch biopsy, that is essentially what this is. There are 3 different sites that a skin sample is taken from: above the ankle, above the knee, and at the shoulder. And essentially, it's a very small, almost like a core sample that gets taken from the skin, puts into a couple test tubes, and gets sent off to a lab for interpretation and to evaluate for that abnormal protein, that alpha-synuclein. The nice advantage of this, compared to the DAT scan, doesn't require any kind of medication, pauses. Doesn't matter if people continue, discontinue. Those things don't have any kind of bearing on the results of this test. As you can see, we're getting closer to the numbers that we would like, sensitivity being 95% and specificity, again, 97%. And so here is some pictures to kind of give a visual representation of what we're talking about. And so when we say a punch biopsy and a core sample, this is a cylinder right here. You stick it into the skin and it basically clips out this little cylinder sample of the skin. And you can see a couple other more realistic pictures here and for representation of the size. A pretty common question is, if I'm on blood thinners or aspirin, am I still able to get the procedure? Yes. There usually is very controllable bleeding, even in people that are on some blood thinners. We may just need to hold a little bit more pressure. I know people will say, we can throw like a single stitch in if needed or use some skin glue. I personally have never had to do that, even in people that have been on some blood thinners. Usually just requires a little bit more time holding pressure with gauze after the procedure like this. And usually, the bleeding stops on its own. Takes, usually I tell people a couple weeks for it to kind of scab over and heal. But really, there's no special kind of care that needs to be done to kind of manage the sites afterwards. I know I already talked about the 3 sites, but here's again a representation of exactly kind of where we're talking about taking these samples from. Another type of test for, again, alpha-synuclein is one taken from the actual spinal fluid. So we call this a CSF assay, cerebrospinal fluid. Now, again, this is testing for the abnormal protein, that alpha-synuclein, except instead of testing for it in the skin, we're looking a little bit closer to the direct source, which is in the spinal fluid itself that surrounds the spinal cord and the brain. And so it does require an additional procedure, a spinal tap. Now, depending on what facility you go to, sometimes people will be able to do this in the clinic itself, again, as a separate procedure from a visit. Other places, such as my facility, we don't really have the resources to do it in the clinic. It's usually just a little bit easier to have people go to the hospital. We'll set it up with the radiology department. They can do it with imaging guidance so that they're getting into the space very well. And basically, as you can see here, we go into the lower back, put the needle into the spinal canal, take out some of that spinal fluid. And again, that spinal fluid gets sent off to a lab where where they can test for that abnormal protein. This one, again, has numbers that are, on the higher end of the spectrum. Sensitivity 88%, specificity 95%. There is one thing that I came across where, most of the time it seemed like this procedure was always a self-pay. It didn't seem like insurances were really too keen on this procedure as opposed to the other ones. Um, Depending on financial situations, I usually just steer clear of this and will use other resources that a patient's able to afford. I guess I will talk one other feature about this. Some people talk about the side effects of the procedure itself. Usually, these are very well tolerated. The most common side effects of a spinal tap are really related to the procedure itself, taking some of that fluid out. Some people will get what's called a spinal headache or a low CSF headache. It's usually self-limiting. I usually tell people if they're going to have a spinal tap, um, the caffeine, so like, taking some kind of pop or like a caffeine tablet or even a coffee after having the procedure usually prevents the headache from ever happening. There are rare instances where the track that the needle goes through to get into the spinal canal remains open, and you actually have a little bit of ongoing leaking of the fluid out through that area, and that's called a spinal leak headache. Very rare instances that occurs, but if it does, you can have a lingering headache after the fact, and sometimes it actually requires another type of procedure very similar to this, where they put the needle back into the spine and they do something called a blood patch to seal off that leak and let the body kind of heal it up and stop the fluid from leaking out again. Again, very rare, but it is possible and something that we counsel people on. So genetic tests. I get a lot of questions about this as I'm making a diagnosis. you know, I have a family member that also has this, or, I'm the first one in my family to ever have this. What's the risk of my children or grandchildren going on to develop Parkinson's disease? The overwhelming majority of Parkinson's disease cases are sporadic, meaning even in settings where you have a family member that was diagnosed with Parkinson's disease, there usually isn't a genetic basis for that to account for. Um, there are some good genetic counseling and tests that are available, but mostly all are only covered once a diagnosis of Parkinson's is already made, so that then genetic testing can be done to really see, okay, you have Parkinson's disease. What is there, or sorry, what is the genetic predisposition for the Parkinson's disease if there is one? Most of the time, there is no specific variant that accounts for the disease. I do have listed here some common ones that are tested for. And once you've been established with a diagnosis of Parkinson's disease, there's actually a great resource, the Parkinson's Foundation. They have a free genetic testing for any patient that already has a diagnosis of Parkinson's disease. They will send you an at-home testing kit with instructions on how to do it that, again, looks for all of these different variants that may account for it. Um, People will ask me, is there a benefit to doing genetic testing at this point? And I would say it doesn't change the management strategies that we utilize for Parkinson's disease. But, you know, the whole theory is that as we get more information, which is why we do these kinds of studies, it opens avenues to explore the differences in Parkinson's disease patients. And as we are able to explore those further, then that opens up more avenues to search for potential treatments that go a little bit further than what we're able to provide right now. And so, you could be part of the endeavor of finding, medications that halt the disease, or even, the golden goose, which is, obviously a cure for this at some point. I mention this test separately because as of right now, this is the third type of alpha-synuclein test that is technically available. Right now, it's in the research stages, and so this isn't commercially available for a provider to order for patients. It does seem, a simple and more desirable type of test than doing a spinal tap, just a blood test like we get for many other diseases or monitoring. But as of right now, this is still in the research process of trying to figure out how valid it is and can be as a actual testing tool. And so as of right now, this is not on the market, but is something that's still in development and being looked into. And so an MRI, a lot of times people will come into my office and say, I had an MRI or I need an MRI to test for Parkinson's disease. And this is one that I really wanted to kind of clear up for people. An MRI is not a standard test that we think of for Parkinson's disease. Providers will usually order this if there's any kind of confusion or other potential medical issues that are going on. Because really, what the MRI is looking for with this question isn't that the MRI is going to show us something that is supportive of the diagnosis of Parkinson's disease. But what we're really looking for is actually something that shows up on the MRI that would account for symptoms that is not Parkinson's disease. Things like a tumor or abnormal iron accumulation, um, things of that sort that, we do it as a way to rule out other causes. And so really we expect if it's Parkinson's disease, your MRI should be relatively normal. Okay. And so to kind of clarify that a little bit, I wanted to present this. And so with this picture, these are actually two patients that I've seen. One of these is normal, and one of these is a patient with Parkinson's disease. Now, I don't expect you guys to be a radiologist or anything like that. Um, but what I want to point out is actually, there's some minor differences between the two. But really, what we look for is this area in the brain here. This is the basal ganglia. And, you know, these are fluid spaces. And really, both of these look completely normal. One of these patients has Parkinson's disease and the other does not. If you were to ask even a very seasoned neurologist and a movement specialist which one is which, you would probably get something close to 50-50 split. And I could switch these labels back and forth, and I would never get pushback from any of my other providers. So just something to keep in mind that if you have an MRI, it's not to test for Parkinson's disease. It's really looking for things that would account for symptoms that aren't in line with Parkinson's disease. We do that because most of the time, if there's other things found, there are much different treatment strategies that need to be employed compared to how we would treat a Parkinson's patient. And so I wanted to keep things simple. These are the tests that are on market right now, the tests that, providers and movement specialists together will employ as needed, some in combination, some in isolation. It's really kind of guided by, again, the clinical context, the history, the physical. And a lot of times, a movement expert won't need to order any of these tests. Some people just like the reassurance of having a test to kind of fall back on with some kind of data that helps people kind of put their mind at ease. And, I'm of the mindset I never push back on a patient that, questions my ability to pick that out clinically. If, they have any question or just kind of want that study to support the diagnosis, happy to order it for them and kind of give them as much information as I can. And so with that, any questions about anything?
Looks like there's a few. Thank you, Dr. Oblack. There's two in the chat so far. I can read. I'll read the first one. Around what age or stage do you see most people come in for a diagnosis?
Good question. Um, I would say probably the most common age is between 60 and 70s. That's the really most common age for the presentation of Parkinson's and a diagnosis to get made. But anytime after 60 is really pretty reasonable. I have people come in their 70s and their 80s. The biggest risk factor for Parkinson's disease is advancing age. And so, just to say that the most common age range that we diagnose Parkinson's disease is in their 60s doesn't mean that we can't come to a new diagnosis anytime after that as well. You can also get them earlier, but those are a little bit more rare, but definitely not impossible. A category of patients that we call young onset Parkinson's disease.
Is the young onset Parkinson's disease category increasing? Is that I've heard it's the fastest growing. I was curious about that.
It is growing. I don't know if I really would consider, more people are developing Parkinson's earlier in life, or is it the fact that, our ability to recognize the findings have gotten so much more widely accepted and knowledge based that people are just coming to attention earlier and people are able to make that diagnosis when it's appropriate.
Thank you. I'll read one more from the chat, and then Donna, you're welcome to unmute yourself after that, as I see your hand is raised. Does a positive alpha-synuclein test diagnose Parkinson's, or can you be positive and not have Parkinson's?
Good question. Yes, so that is the case with actually every test that we discussed here. I guess I only explicitly mentioned it during the DAT scan, but yes, the skin biopsy can be positive when in fact you do not have Parkinson's disease. There are a family of disorders that have the abnormal protein throughout their body. We call them synucleinopathies. And so there's many different types of synucleinopathies, and all of them would actually give a positive test result. And so again, that number that we're always reaching for, that 100% sensitivity, 100% specificity, would eliminate that confusion. But unfortunately, we have to work with what we've got, and it's really open to the interpretation of the results, the history, the exam. And then when we get these results, okay, yes, it kind of narrows the field of the diagnoses that we're potentially analyzing for. But no, you can have a positive test and in fact not have Parkinson's disease.
Thank you. Donna, go ahead.
I have a lot of questions because I'm wondering, I bring up an alternative view about Parkinson's that I wondered if you're considering, Dr. Oblack, that you're in touch with the group that's growing outside of the normal Parkinson's neurology beliefs that Parkinson's is more of a stress condition than a lack of dopamine. And that, like Dr. Zachar Bernstein's research, when he's going to enter into a phase 2 trial that says, in fact, he studied postmortem, a meta-analysis on postmortem brains, that it wasn't a lack of dopamine, but an excess of dopamine in the actual neuron, and that's causing the neuron not to be transported out, and then you're feeding extra dopamine into the brain. But I have trouble believing all this when you look at that point of view. Like, how do you measure sensitivity and specificity? How do you measure that? Are you looking at postmortem brains? How do you diagnose Parkinson's? Because we don't have a biomarker. So how is that even being measured?
Is that part one, or do we have more?
Oh, I have more. That was
Let's first start with that one then. Yep, go ahead.
The only other one I wanted to ask, so I wanted to know how specificity and that was being measured. And the levodopa test, I'm not sure how that's run. And then further tests that other doctors are coming out with, like Dr. Greg Eccles. I don't know if you're familiar with him and his Energy for Life centers in Arizona. but they send out a test kit for you to take before you even consider to look for things that possibly you're being diagnosed with Parkinson's, but it could be caused from toxins. That's what we keep hearing, but we do no tests on toxins in our body. And he has a test kit that's $5,000 that he starts his treatment with, where you pay $5,000 and you get certain blood tests, a stool test, and different tests. And what do you think about those tests?
Sure. All right. So let's start with step one. Great question in terms of how we're coming to these numbers. You are right. Most of these tests, aren't in studies where they confirm the results with postmortem studies. Usually, the way that these tests kind of come to that data is really we do these tests and then follow for a period of time until, as Parkinson's disease continues down the line, more and more movement experts would come to the same conclusion and say, yes, this is definitely clinically in line with the diagnosis of Parkinson's disease. And so that's usually how we wind up finding those results. We give it the test and then follow much longer down the line. And then at that point, we say, okay, have we reached a definitive clinical diagnosis or have we not? And that's how you wind up going back to the previous test and saying, okay, what did the test show? Was it positive or negative? And is it in line with what was established later on down the road whenever it was felt to be at a point where most experts would agree on the final diagnosis being in favor or not in line with Parkinson's disease. Um, there are brain bank studies, but there just really isn't enough of those kinds of details and information to, realistically check these types of tests to the extent that they need to be early on in their process of testing to be able to make them hit market the way that we would like them to. So that's part one. In terms of the levodopa trial, really it's not an instantaneous test that we do like in the office. You initiate Parkinson's medication, carbidopa levodopa, which is Sinemet, and over a period of time, you'll increase the amount that a patient is taking. And the goal is at some point, you reach a dose where the patient will say, okay, yes, I noticed improvement in this feature, this feature, this feature. And that is, a diagnostic clue that, okay, yes, you probably have Parkinson's disease because the the symptoms that you have, the physical exam features that you have, and you have improvement with the medication that's supposed to improve Parkinson's features, that is how we come to the conclusion that yes, the levodopa trial is in support of a diagnosis of Parkinson's disease. And then last question, I'm not familiar per se with the testing kit that you're mentioning. Um, are there many different things that I will send lab work for this, that, and the other thing whenever I have a patient come in with their first kind of visit saying, okay, I think I might have Parkinson's disease. And so I'm sure what you're referring to probably has those types of labs and tests incorporated into it. Um, I'm I'm hesitant to say anything more than that because unless I were to actually look at the exact testing kit and see what all he's sending for, what might be overkill, what is common, what's not. So I don't want to say anything more than that without first saying, are there other tests than these specific ones that I mentioned to ensure that, we're not missing something a little bit more treatable? Yes, there are, specific heavy metals that I test for in the blood that can contribute to symptoms. Do we know about toxicity exposure that again kind of opens a patient to develop Parkinson's symptoms? For instance, old war veterans with Agent Orange exposure, those kinds of things, a lot of patient population from Camp Lejeune. Um, but there really isn't a test to go back and say, okay, yes, you had this toxic exposure, and yes, I can confirm that it's because of that that you're looking the way that you are. Unfortunately, that's really based off of, clinical history. Yes, I was in this situation and I did have an exposure, and now I'm having these types of symptoms. Outside of that, there isn't a specific test to directly link them together.
Did you hear of Dr. Bernstein's studies? Dr. Zachary Bernstein's studies?
Is that the one from Arizona that you were mentioning?
No, this is a different doctor. He's a cardiologist, and he's looking into Parkinson's, and he's the one that looked back at the original research done on levodopa, the drug, and how it was done. And he studied the brains of the brain bank of Parkinson's brains, and he determined that it wasn't an excess. It's not a dopamine reduction problem. It's that you have an excess of dopamine in the actual brains. And he's developing a drug that actually stops levodopa for a certain point of time. I'm not necessarily going to say I agree with that, but what if he's right and the overlying hypothesis that we're basing all this research on over decades is wrong, that it's not a lack of dopamine and we're feeding extra dopamine? So what's that doing? When a healthy person takes dopamine, what happens to them? It's an addictive drug. It's like heroin.
So, good question. And I'm not going to talk to that one specifically because it is actually in a cohort of the larger theory, which is as we've done more research and we've discovered more about the pathology, the actual breakdown in the system that creates a Parkinson's picture, we have actually found that not all Parkinson's patients have the exact same pathology. You know, the nervous system is a very complicated network. I'm not going to sit here and try to think that I can simplify it to a level that I feel like it would be appropriate. But there are many different points in the pathway where, you know, really things could go wrong that present these same symptoms. That's why, Parkinson's disease itself, it's really only one specific type of disorder that can cause the symptoms that we see. Now, are these all specific diagnoses of themselves, or is it possibly a spectrum and Parkinson's disease is just one specific thing on the spectrum of disorders? Entirely possible. So could there be, for instance, if we have a lack of dopamine in the system that can't send signals because there's no dopamine to send a signal, would that be much different than if a brain cell had a surplus of dopamine inside of it, but there was something wrong with its ability to use that dopamine and actually get it outside of itself to make those signals happen? Ultimately, the end result would be the same, whether the dopamine is trapped inside the cell and not getting out to signal the other cells, right? The other cell isn't getting signaled, versus the same effect would happen as if this cell didn't have any dopamine at all and couldn't send that signal. And so is the running theory, that it is degeneration of cells and a lack of dopamine? Yes, it's the most widely accepted one because it has been around the longest, but the field is growing in its knowledge, and I think most people would agree that as we have been discovering more variations in the breakdown of the system, I don't think there's really going to be one answer that every Parkinson's patient fits. And that's what again makes it a little bit difficult because, well, this whole time we've been treating every patient the same. We've been trying to give them dopamine, like you said, and maybe that's not what every patient needs. And in fact, they need to have, the pathology addressed at a different point in time, or different line in the system. But until that information becomes more clear, unfortunately, there's going to be no way to adjust that treatment for each individual person.
Then just one more theory that there's a growing population that doesn't believe a single pathology will ever fix Parkinson's because it's a whole body condition that's kind of like you're stuck in flight, fright, and freeze. It's a stress condition, and you're stuck there, and it takes changes in your thoughts and subconscious and dealing with past traumas to resolve Parkinson's. And that's why everybody's different because it's depending on how you grew up, what your traumas were. And there's a growing group that are addressing this. But again, that points to the problem that giving people levodopa is giving them adrenaline. They're giving them more adrenaline to be stuck in this stress state. So I'm just concerned, I'm looking for a cure, and I've seen people recover from various means, like Howard Shifke's fighting Parkinson's drug-free. And I'm just worried that levodopa is a wrong thing to do. Yet nobody wants to admit it because we've been doing it so long.
So it's a good question. Do I ever buck the system in terms of if a patient comes in saying that they want to try to be off of medication and see what it does for them? Certainly, I never fight a patient whenever they want to see what happens for themselves. I will say every patient that I've treated that I've clinically come to terms with, yes, this is definitively Parkinson's disease, and had been treating them with levodopa. Any patient that has ever tried to reduce medication without some other means of dopamine getting into their system has not done as well with being on therapy. Now, does that mean that maybe I've just, the most common type of Parkinson's disease is the one that's going to respond to levodopa? Entirely possible. But until more data is recovered for it, I would agree, probably most people, even if they're given the chance to try and reduce their dopamine, most people are going to find that they do worse. Now, in terms of the other part of that question, what happens if you give healthy people dopamine that don't need it? There were studies done on that, and actually have found that levodopa doesn't cause undue harm to a patient that doesn't need levodopa therapy. But again, I will say that that study had been done a long time ago. Could things have changed? Could, our testing methods be more precise now that maybe find something that wasn't found before? Possible, but for the most part, I would say outside of the direct side effects that can happen from the dopamine itself, long-term side effects I haven't seen to be a problem for healthy people taking levodopa.
They don't develop dyskinesias or hypotension problems.
Healthy people do not. They could develop low blood pressure because that is a direct stimulation effect from the dopamine. But healthy people don't go on to develop dyskinesia because of levodopa therapy.
But they would develop hypotension.
They could, but that would be not a long-term result. That would be as long as they are taking the dopamine, and then once the dopamine would be stopped, because again they're healthy, then the body loses the dopamine signal and the blood pressure would probably return to normal.
Just one
Okay.
example. Have you had any patients reduce levodopa? Have anybody been able to address exercise and diet and then been able to reduce levodopa?
Yes, temporarily. Exercise, if a patient adamantly adheres to an exercise program, again, this is really more early on stages of the disease because exercise itself can improve a bodily function, both from a Parkinson's standpoint and to help kind of slow down progression. So I have had people early on in the disease actually come into my office and say, okay, I'm going to start exercising a lot more. I'm not ready for medication. And they actually go on to do pretty well for a period of time until such a point that they do need dopamine therapy. Yes.
Okay, well, let's move on to, thank you for those questions, Donna. Very thoughtful. Thank you, Dr. Oblack. Let's move on as we have a little bit more time for questions. You can unmute yourself and just ask the question if that's an easier way.
I had one more question on the MRI. When you said that doesn't really, you can't really tell what Parkinson's or not Parkinson's, is that just because it was a snapshot in time? Or,
No. So actually, the degeneration that we see in Parkinson's disease visually doesn't become very apparent. So, if you take a healthy patient at one point in time and a Parkinson's patient at one point in time, give them 10-ish years even, let's say, and then again do an MRI, accounting for differences in what a patient might go through in those 10 years, their MRIs again would be.
Be able to speak.
We're all muted, so he can talk.
We can hear you now.
Oh, I just muted. You're welcome to unmute yourself in just a moment. Go ahead. Go ahead, Dr. Oblack.
Oh, no, I was actually
Okay.
opening the floor to them. Yep.
Okay, got it.
Casey,
Go
this
ahead, Springers.
is Paul calling.
Oh, yes, Paul.
I was asking if you discovered or you discussed the DAT scan.
Yes, that was
Did I-
discussed a little bit earlier in the
If you could,
webinar.
okay, if you could just give me a little shorthand, I'll listen. Thank you.
Okay.
Sure. So I'll just kind of go back to that slide real quick. So the DAT scan is essentially, you can think of it as just another kind of image of the brain, but with special characteristics. We give people an IV, we give them a radio tracer, and that radio tracer goes up into the brain, and this is what you see on the screen. An area of the brain lights up, and that basically just signals that that area of the brain is healthy and absorbing that tracer, and that's what happens in a normal brain. In a Parkinson's disease patient, along with certain other diseases, that area of the brain doesn't absorb the tracer well. And so you won't get the same kind of normal lighting up pattern. You get, almost just two dots as opposed to a nice comma shape. And in that case, we call that a positive test, but the positive test doesn't in fact mean it has to be Parkinson's disease. Other things can give a positive test as well.
Thank you.
Sure.
and the DAT scan was where you have to withhold medications?
Correct. Specific medications, not all medications, but only the medications that would interfere with the study. Typically, that's like depression, anxiety medications. There's actually a growing list of the medications that interfere with it, and so that's why it's important to discuss, all of the medications that you're on before you would have this test done.
Would you have to withhold levodopa?
You should, yes.
So that's the main drug you're on, you'd have to withhold to get a DAT scan. Okay.
Correct, but levodopa is very fast acting and not long lasting. And so I would usually just tell folks if they're going to have a DAT scan and they're on levodopa therapy, I usually just tell them to hold their medication for 24 hours.
But some
Right.
you have to hold for 2 weeks or 3 weeks.
Yeah.
Okay.
Alita, we'll be right with you. The Springers have been waiting, and then you, Alita. Go ahead.
Okay, we're calling to check in. If you could address the issue of iron in,
You mentioned it, excuse me, you mentioned it briefly. Could you expand on the influence of iron and what iron abnormalities contribute to symptoms?
Sure. So I don't want to be too vague with this. There's a lot of different iron abnormalities that can happen in the blood. That has actually no bearing on this. There are a group of disorders, probably the most common one being PKAN, PKAN. And basically, what can happen is inside the brain, you get accumulation of iron. And when that iron accumulates there over time, can also cause symptoms that look similar to Parkinson's disease. There are other features that, as time goes by, they separate themselves by looking very different over time, but early on in the disease, they can look similar. And so it's something that, we as providers should be looking out for. And again, the MRI or a CT scan over time would show something like that.
So how does that bear on that?
Sorry, could you repeat that?
Superficial siderosis, what do you see any relationship with that?
So superficial siderosis could be an example of that. It has a pretty wide range of the way that it presents itself. Again, could that present a similar picture to a Parkinson's patient? Yes. But whenever we would do the scans to rule out other causes, that would be something that would reveal itself and then go into the counseling from the provider about what that would mean and how to interpret it moving forward.
Thank you.
You're welcome.
And Alita, go ahead.
Hi, thank you. My husband was diagnosed with Parkinson's in 2017 after we retired and moved to Virginia. Last year, he was losing his memory and his executive function. We thought because of Parkinson's. Toward the end of last year, he was diagnosed with cardiorenal syndrome. His kidneys were failing and he had some heart condition, and he started dialysis in hospital. I have noticed within the last month that some of his executive function is coming back and his memory is improving. Is that because he's on dialysis? And the process of dialysis in the blood and the brain, is that what's happening, doctor?
Great question. So that opens up a whole other spectrum of kind of what this disease entails. And so not just Parkinson's disease, but neurodegenerative conditions in the brain, dementias, Alzheimer's, anything in this category. The brain loses its kind of what I call reserve, right? So healthy people can deal with insults. Insults could be a physical injury, could be toxins, things that accumulate that, are outside the body's typical baseline. When that happens for a normal person, our brain is able to, accommodate those changes and still function at a pretty normal level. Thank you. When there is a neurodegenerative condition like Parkinson's disease, what happens is our brain loses that ability to really kind of maintain normal functioning while also dealing with these kinds of insults. Insults being, again, a physical injury, it could be emotional stress, it could be more medical conditions like heart failure, kidney functions, not keeping up with what they should, liver disease, and those kinds of fluctuations will, in fact, create a deterioration picture. And what I tell patients is, if it's a temporary setback, so for instance, kidney injuries leading to accumulations that the kidneys are supposed to kind of get out of your body, temporarily, if those things are accumulating, you can get a worsened clinical picture, not just mentally, but also the physical features of Parkinson's can worsen. If that is corrected, you can actually see improvements back to where somebody was prior to that insult occurring. So, based on what you're describing, I actually would say you probably are seeing some improvement because the body is getting back to its more normal state. You're welcome.
Oops, it looks like we're at time. Thank you, Dr. Oblack, and thank you, CND Life Sciences. And if you have any questions about the skin biopsy test, you're welcome to email Andrew. His email address is in the chat, or you can email me and I will get in contact with him. Thank you, everybody. Very informative. Thank you for joining. See you
Have a
next
good one.
time.
Thanks, Dr. Oblack.
Thank
You're welcome.
you. Goodbye.